We'll begin, sir. I welcome
Sure.
Dr. Ajay Gujar and Dr. Jayesh Parekh as our examiners today.
Hi,
And
hello everybody. Yeah, yeah,
good
I'm here.
evening, sir. And our first student today is Dr. Shravani Tripathi, who is a third year student at GMC Nagpur.
Okay.
The next slide, Jen. Yeah. So this is the spotter that you've been presented with during the exam. So first question is just identify the instrument or the procedure, and then the examiners can take over.
Hello,
Yeah.
Yeah.
am I audible?
Yeah,
Yes.
Good
yeah,
evening,
Shravani.
respected
Yeah.
teachers. This is Dr. Shravani Tripathi.
Okay.
I'm sorry, I'm from IGGMC College from Nagpur.
Oh, sorry. Yeah. Please go ahead.
Ma'am, this is a percutaneous endoscopic gastrostomy tube.
Mm-hmm.
Uh,
Okay. You are right
I
so
mean,
far.
this is a gastrostomy tube.
Right.
Okay. Yeah.
So, sir, any further, please take away the questions.
Okay. Okay. Okay.
Yeah.
So, why this gastrostomy must have done? What must be the reason in this patient? Do you know anything about this patient?
No, sir.
No,
So, what?
basically, sir is trying to ask you the indications
Yeah,
of a PEG
indication.
tube.
What
Okay.
what could
Yeah.
be the indication? Because can
Sir,
you
if
see any other scar on this abdomen, her abdomen, her or is his
no,
abdomen?
sir.
No. So
No,
it is
sir.
pure.
Since there is no scar,
Mm-hmm.
I'm assuming that the procedure would have been done endoscopically, and there has been no previous surgery.
Mm-hmm.
If there are any upper GI obstructive lesions like in esophagus,
Mm-hmm.
or if there are any complaints of dysphagia or dinophagia, or
Mm-hmm.
any head and neck cancers,
Do you
then
think this patient is a
we
good,
provide enteral
well,
nutrition.
do you think this patient is a cachexia undernourished or averagely nourished? By seeing this
Uh,
picture,
Yes, sir. The patient appears to be moderately nourished, sir.
yeah, it's not cachexia or something like that, correct?
Yes,
It's
sir.
not malnourished, okay?
Yes,
So
sir.
what could be the indication?
There could be, sir, if there is any corrosive injury to the esophagus,
Mm-hmm.
uh, or any benign strictures in the esophagus.
Mm-hmm.
Uh,
Okay.
Shivani,
Anything? Yeah.
Shivani, in a case
yes,
of
sir.
corrosive, when will you do the gastrostomy? In a case of corrosive acid poisoning, when will you do the
Yes, sir.
feeding gastrostomy?
Sir, it should be done, sir, after, sir, after about 72 hours.
No, tell me the indication. I'm not asking the durations. Beforehand, you have some information, then you do. Otherwise, usually we are doing the feeding jejunostomy. But when will you do the gastrostomy in case of acid poisoning?
Uh,
Why you won't allow you?
uh,
Why you don't allow the patient to have food orally?
Hmm. So
They
that
are
is the hint. That is the hint.
Sir, sir, since there is a risk of perforation, the tissue
Mhm.
becomes friable, sir.
So in another terminology, I just tell you that when the only esophagus is affected and there is no
Yes, sir.
obstruction at the pylorus, it is better to perform gastrostomy. If stomach
Yes,
is also char and pyloric stenosis is there, you should not perform
yes, sir.
gastrostomy. Okay,
Yes.
so go ahead.
Any other indication you can think?
Um,
Just think what can happen to stomach. Is it necessary that something happen proximal to the stomach? That's why gastrostomy has been done. Anything else? We used to do
yes,
a
sir.
feeding gastrostomy for the patient who can't take orally and the nasogastric tube is for longer period of time.
Yes, sir. If a patient requires a feeding for more than 4 weeks, uh, if the patient requires enteral feeding for more than 4 weeks, and he is not able to take
Which
orally,
indication?
then, sir, if there is any oral. malignancy or
Shivani,
oral
sir's
lesion.
questions is when will you do? Indirectly, you are telling the when you require 4 weeks. But the most thing is when will you require expected these patients require 4 weeks of feeding. By which parameter will you decide?
For example, it's very young patient
Yeah.
and you want to feed
Yes.
him for some purpose. Something has happened to him and he's not able to eat, and we are giving a nasogastric tube feeding for a longer period. But patient is going down, weight is reduction because we cannot feed a good quality of the food. What is the
Yes.
indication? Just think. Which surgeries other than the GI tract surgeries?
Yeah.
Other than GI tract surgeries, we used to do a lot in our time, but that time PEG was not there. So we used to do open gastrostomy or open jejunostomy for these patients whom we want to feed. Any accidents?
Patient is bedridden, comatose, or
Uh,
vegetative state
yes, sir.
sometimes.
In any neurological conditions, head injury
Oh, yeah.
patients.
Yeah, you just have heard the case of the euthanasia new case.
Yes, sir.
He was
Yes,
on
sir.
what?
Recently.
Huh?
Hmm.
He was on
Yes,
feeding
yes.
gastrostomy. Yeah. Okay. Any other indication for feeding gastrostomy?
Yes.
Nowadays, endoscopy does everything, and surgeon job is going down. Some
Hmm.
condition in the stomach which you can do, which also happens to colon. Have you heard? Something happened to colon, and you can do colonoscopically correction.
Um,
Something,
uh,
something with a sigmoid colon
sir, uh, volvulus,
happens.
sir.
Yeah, happens in elderly. So
Gastric
can stomach
volvulus.
gastric volvulus? Have you heard about it?
Mm.
No, never heard. Okay,
Mm.
okay. Now what? Why the feeding gastrostomy and not an nasogastric tube? What is the advantage of the feeding gastrostomy tube over the nasogastric tube?
Sir, we can provide the quantity of the food can be increased. Also, the consistency, sir, we can provide solid food.
Quantity can
Uh,
increase or something else?
uh,
What happens to RT feeds? So what happened when you give nasogastric feeds? What number riles tube you put in a nasogastric feeding at the most? And what happens we
sir,
start feeding through the nasogastric tube?
sir 16 or 18 French RT tubes are used.
So
Sir,
how they prepare these RT feeds, whenever you want to give a nasogastric feed, you every time you have to be take a strainer
strain
and
it,
you have to
sir.
strain
Yes, sir.
because
Yes,
otherwise
sir.
it get blocked very
The
easily and you have to,
particles can block.
yeah, so
Yes, sir.
every time you have to change every 3 days, 4 days, sometimes 15
Yes,
days,
sir.
1 month, but any other complication can occur because of the nasogastric tube. That is one. It get blockage again and again.
Yes, sir.
If it
Uh,
is blockage, it will may regurgitate. Then what will happen?
Yeah. Yeah,
aspiration risk
regurgitation.
is there, sir.
Aspiration pneumonia.
Yeah.
Yes,
That
sir.
is a,
Yeah. So regurgitation
another
chances.
question, Shivani. In this case, it is gastrostomy is seems in the midline. See,
Yes,
it
sir.
is in the midline. Exact, it is insertion in
Yes,
the
sir.
midline. What is the
थोड़ा
normal point of insertion usually?
थोड़ा सा left to the
Sir,
midline
usually
दिख
it is
रहा
in the
है.
Ah,
left hypochondrium, sir.
so why it is here in the midline? Can you imagine or predict why it is so?
Uh, Sir, it must have been put in the distal part of the stomach, sir.
So why they don't want to put it in the proximal part? What will happen to the proximal part?
Uh,
Proximal part maybe the have
the
some concerns.
it must
That's
have
why
some lesion or some it
that
might have
diagnosed
some
from the upper
polyp.
GI scopy, which is
Yes,
blocking the esophagus as well. So that's why they want to keep
yes,
it in the distal part. So everything goes in the duodenum and in the
yes,
distal tract. Okay.
yes.
Have you seen doing this pig or open gastrostomy anytime? If the
Uh,
endoscopic things are not there, so sometimes we do the open gastrostomy. Have you seen? Have you did any time the gastrostomy procedure?
no, sir, not at our institute.
Never. You have never seen
No, sir.
pig also?
Sir, I have seen an endoscopic procedure being done, but not an open gastrostomy, sir.
Have you seen an open jejunostomy feeding? Never? After some
Yes, sir. Feeding
surgeries?
jejunostomy, I have
So,
seen, sir.
so feeding jejunostomy, after which surgery, open surgeries, when you do lot of open surgeries, then surgeons
Yes, sir.
prefer that we should do the feeding jejunostomy in this patient,
Sir, after an esophagectomy, sir.
esophageostomy. Then why? Why after the total
Uh,
esophagectomy and all these big procedures we do feeding jejunostomy?
Sir, after an esophagectomy, generally, sir, since the stomach is used to form the conduit, sir, and anastomosis, so we cannot directly feed orally, sir, because the anastomotic sites
See,
might leak.
whenever you are
So,
doing major, supramajor surgeries, okay,
yes, sir.
especially for cancer surgeries, patient is already
Yes,
malnourished, hypoproteinemic, so there are high
yes.
chances of the leakage, okay, of the
Leakage.
anastomosis, and then
Yes,
TPN has its own complication, and you can it's sometimes non-affording to the patient. In that case,
yes, sir.
the feeding through the jejunostomy is very easy, and sometimes
Yes,
whatever leak or small even high output fistulas can stop if you feed and give good calories to the patient through the
yes,
feeding
sir.
jejunostomy. Correct? That's why we
Yes, sir.
do many times a feeding jejunostomy in any major surgeries on upper abdomen. Okay?
Yes, sir.
Yeah.
Yes.
Anything else?
Sir, sometimes after a Whipple's procedure also, feeding
Yeah,
mechanism
sometimes.
can be done.
Why after Whipple procedure you do the feeding
Sir, since
jejunostomy?
Sir, since there are three anastomoses in the Whipple's
Yes.
procedure,
Yes.
the chances of leakage increases if we start oral feeds early. So we do a distal feeding
Not that
jejunostomy,
way,
which
not that way. It's because sometimes the anastomosis are there. Sometimes there is a lot of pancreatic juice, leakage. So
yes,
in
sir.
that case, it's better to feed the patient, and
Yes,
give good
distal to all
calories.
the anastomosis.
Sometimes
Yes, sir.
patient is a lot of nausea, is not having adequately for first 1 month, 1.5 months after surgeries. Okay, and
Yes, sir.
leakage is there, high output fistula is there. Okay, so
Yes, sir.
every time it does not leak, okay, but give lot of
Yes, sir.
calorie loss, lot of things get lost in these surgeries, and you have to feed the
Yes, sir.
patient properly, and it
Yes, sir.
becomes like a lifeline for that patient. Okay, and
Yes, sir.
feeding enterally is always has a good
A
result
better
rather than the
option. Yes,
anything
sir.
else. Okay, then
Yes.
so you should see the feeding gastrostomy or jejunostomy sometime,
Yes,
at least
yes, sir.
not endoscopically, but you can see open surgeries how they do.
Yes,
How
sir.
they do,
Sir,
how they
for
do feeding.
feeding
Which is better,
jejunostomy,
gastrostomy or jejunostomy, you feel?
sir, it depends upon the indication, sir. If the patient is
No, but
having
if
any
I have opportunity to, it's open surgery, and I have opportunity to do the gastrostomy or jejunostomy, which is better?
sir, I feel
I'll go.
jejunostomy is
What
better.
you will go for? Yeah, yeah.
Sir, feeding jejunostomy is
Of
better,
course,
sir.
feeding jejunostomy. You should go for feeding jejunostomy because ultimately stomach you feed a lot of things and there are a lot of complications by
Yes, sir.
feeding in the stomach. But feeding jejunostomy works better than the gastrostomy.
Yes, sir.
Okay, so how you do it? You know any methods
Sir,
of these gastrostomies or open techniques?
yes, sir. For jejunostomy, sir, we usually, if we can do either a midline incision or a left
How away
paramedian
from the
incision, sir.
anastomosis? How much away from the anastomosis you should go for doing feeding
Sir, about
jejunostomy?
20 to 40 centimeters distal to the anastomosis, sir.
Okay, 2 feet. Okay, then.
Uh, Sir, we take a portion of the jejunum out and we do an enterotomy, sir.
Hmm.
We pass a jejunostomy tube or a large bore Foley's catheter, sir, of about 22 French. Uh, we do a tunneling technique, sir. We create a tunnel over the Foley's tube, and
Hmm.
then we suture it to the anterior abdominal wall, sir.
Sorry, Steven, tunnel on the follies or tunnel on the jejunum?
Sorry, sir, over the jejunum.
Hmm. So why tunneling is important? Tunneling means what?
Sir, we take seromuscular sutures over a portion of the Foley's tube to about 2 to 3 centimeters, sir, so that the Foley's does not get dislodged and it might cause peritonitis later, sir.
So serosa And muscularis mucosa and mucosa are cut at the same level or different level? Tunnel.
No, sir. Uh, Sir, we take only seromuscular tunneling, sir.
So it is not at the same level, at a different level to
No, sir.
make it slant.
Yes.
So
Yes,
opening,
sir.
so that it does not reflect back directly is not possible. Though there is a,
Yes,
but
sir.
the tunneling is important for that. Okay.
Yes.
Next question is, you have done the everything and patient's relative is asking what to feed. How will you decide the diet plan for feeding gastrostomy? Diet plan.
Sir, initially we will start with liquids or clear liquids.
Liquid, everything
Then,
tolerating, it is not regurging back, no leakage. Then after to build up the weight. So how will you advise the diet plan?
sir, we will check the weight of the patient, and sir, we will sir give 1 gram protein per kg body weight, sir. And for
And
calories, sir,
another
since the
simple question, what is the combinations of carbohydrate, protein and fat to build up the patient's weight gain?
sir, sir, proteins should be 30%, fat should be 30%, and carbohydrate should be 40%, sir.
Okay, go ahead.
Okay.
Dr. Shavani, if I can ask you, what are the two types of feeding jejunostomy? The one you explained is called what? When you make a submucous tunneling?
Ma'am,
What
it's
are
a
the
Wittgen's
names?
method.
Witzel
Sorry?
and Witzel. What you
Yes,
said,
Yes,
sir.
sir.
Witzel. Okay. Then
What
what
is
is
the
the
other one?
Uh, um,
So basically in your OSCE, if the
sir.
question comes, it's going to come like this only, ki name two types of feeding jejunostomy. So you have to name. Okay. So just read
Yes,
about
sir.
it. Huh? It's
Yes,
very
sir.
Witzel?
commonly done.
Witzel and
Because,
stamps. Okay,
yes,
pursing sutures
stamps.
you take, and very important when you
Yes,
take
ma'am.
that pursing sutures, you see that wherever the tube is coming out, the serosa should be suture to the peritoneum properly.
Abdominal wall.
Yeah,
Yes.
at least 3-4 suture to the serosa to the peritoneum wall through which the tube is coming. So the chances
Yes.
of the leakage goes very less and good track form within 6 to 7 days.
Yes,
Hmm?
sir.
That is very important step while using open feeding jejunostomy. Okay, nowadays how they do the is there any other method endoscopically you can put a jejunostomy tube?
Uh,
What they use
Sir,
nowadays?
we
If
can do
patient is having
a
pancreatitis, necrotizing pancreatitis, patient is not eating properly, having the gastric paresis, vomiting continuously, what they do? They do the open technique of the feeding,
uh,
or what they
sir,
do?
we can also put a nasojejunal tube, sir.
Yeah, what is it
The
called?
fracas tube.
Yeah.
Fracas tubes.
So where they put it? How they put it? How far they put it?
Uh,
Take us tube.
Sir, sir, we put sir about 20 centimeters distal to the DJ flexure, sir.
Okay, they push it quite ahead. Okay, so that
Yes, sir.
we can feed the patient. Okay, any other
Yes.
questions for this case?
Jayesh sir, if no other questions, we can move on to the next call.
Yeah, you can become
I
more
think.
on the next. Okay, yeah.
Yeah, next we can go ahead.
Yeah,
Thank you, sir.
Dr. Kshitija, you are there? Kshitija?
Hello, ma'am.
Yeah.
Yeah.
Switch on your video and Dr. Kshitija is a third year DNP student at Zen Hospital.
Okay.
So this is the CT cut of your patient and kindly give three differential diagnosis.
Who is Kshitiza
Then,
teacher? Who is
sorry, sir.
Kshitiza teacher? Who is Kshitiza
Roy,
teacher?
Roy sir.
Yes, okay, okay.
Go ahead.
Okay.
Roy Patankar.
Yes, sir.
Yeah, okay.
So your
Go
first
ahead.
question is give three differential diagnosis. Then I think the examiners can take over.
This uh, this appears to be an axial cut of a CT scan, and it shows a non-enhancing.
Differential diagnosis. 1, 2, 3. I'm not asking you to read the CT scan. Maybe the examiners will ask you to read the CT scan. I just want what are your differential diagnosis. Then we can discuss more upon the
Yes,
features of the lesion that you are seeing.
yes. It appears to be amoebic liver abscess can be the first differential diagnosis. Then pyogenic liver abscess is the second differential diagnosis, and cystic lesion in the liver.
Can it be hydrated cyst?
Sir, as the any septa is not seen, that is why I did not say hydrated cyst as a differential.
Very
Yes.
good. Very good.
Rather than septa, you can see directly the daughter cyst. Okay, you can see multiple cysts inside. Yeah.
Yes.
Yeah. Yeah. So, you know what is a common presentation of this amoebic liver abscess? How they present usually?
Usually,
This is on the this is on the which side of the patient? Which side of the lobe of the liver is involved? आपका सिटी है ना वो भी थोड़ा सा पूरा नहीं आया है तक it's only a corner of the city. Okay, it's okay. So it's the right side or left side of the liver?
it looks like it's on the right lobe of the liver.
Okay. Yeah.
Can be a segment.
So if we consider it is an amoebic liver abscess, this is CT
Yes.
scan showing why it is going in terms of abscess or a cyst.
Sorry, sir, I did not get the question.
Why this is not hepatocellular carcinoma? Why it is not any other benign neoplasm? Why you are saying it's cyst, or you are saying it is simple cyst, or you are saying amoebic liver abscess or pyogenic abscess?
So the central content is non-enhancing, and there is a rim of thick wall that can be seen, which is different from the other liver parenchyma.
And a very smooth wall.
Yes.
Yeah. Okay. Yeah. So how you must have seen a lot of amoebic liver abscess patient. Okay. So how they present usually clinically how you diagnose them?
In acute settings, they come with right hypochondriac pain, fever with chills.
What kind of pain they have? They have typical pain. Only right hypochondriac pain?
They can sometimes have shoulder pain as well. Can have what we can call as pleuritic kind of pain due to the irritation of
And when the pain increases?
On deep respiration.
Yeah, sometimes their breathing is hampered, and they also get atelectasis of lung.
Yes.
Lower lung get affected, pleural effusion they get, and that's why sometimes they come breathlessness. Yeah. Anything else they come with? You said one is pain factor. Then anything else?
Pain, fever with chills, and they can present with jaundice sometimes, but not.
Jaundice. No, this he won't. Okay, then sometimes they are present in very toxic manner. You know, high-grade fever, tachycardia, dehydration, vomiting, severe pain in abdomen, lot of symptoms. Okay, and typical, you know, pain increases with deep breathing. Okay, yeah. So then how you go ahead with this patient? Now first directly you do the CT scan for this patient, or how you go with this patient? Now this patient presented clinically like this. First investigation, what you do?
So the first investigation we would like to go ahead with the sonography of the abdomen.
Okay.
To look for the organ of origin.
Organ of origin?
To check what is causing the pathology, if only the clinical symptoms are there. Like if the patient is only coming with the right.
No, we will stuck to the amoebic liver abscess or pyogenic abscess. Okay. So first investigation, you did a ultrasonography of the abdomen. It does showing you this kind of the abscess, right? Liver lobe abscess.
Yes.
Then what you'll do?
We would want to know whether the abscess is liquefied or not.
Okay.
Okay.
And then if it is non-liquefied, what treatment you will start?
we will start the patient with IV injectable antibiotics, preferably metronidazole to cover the amoebic and like amoebic antamoeba.
Kshitija, what is the role of chloroquine and doxycycline to liquefied solid amoebic liver abscess?
So the trophozoites which are migrated in the liver, they cause lysis by the use of doxycycline, which can help liquefy the liver abscess.
So does it help? Yes or no?
Yes.
If you have given the choice, pick up either doxycycline and chloroquine, and on the other hand, only antibiotic, which one will you prefer? Does antibiotic has any role on trophozoites of amoebic liver abscess? E. histolytica. Antibiotic.
I'm not sure, sir.
Okay. Another question is, suppose this patient has a multiple SOL in the liver, particularly in the left lobe of liver, multiple, small. Which other systemic examinations will you done after completing abdominal examination? Should I repeat my question?
No, sir, I got your question. If there are multiple small abscesses in the left lobe of liver, then what other organ should I examine? That was the
Yeah, which other system?
question. The distal colon, the rectosigmoid part.
Why?
So, because there are multiple microabscesses in mostly in the left lobe of liver, the source can more likely be the inferior mesenteric vein, which has caused the microabscesses to form in the.
Inferior mesenteric vein drains into the left splenic vein,
Yes, sir.
and splenic vein is supreme mesenteric make the portal vein. Ultimately, it is portal vein. It goes to the right side. Another question is, by which portal of entry infection can occur in the liver? One is the portal vein, another is
The hepatic arteries.
hepatic artery. So from where the hepatic artery infection comes from?
The celiac trunk.
Celiac trunk. From where the celiac, proximal to the celiac trunk? You cannot examine the celiac trunk clinically. So what will you, it is not from directly from the celiac trunk. It is a transport channel from where the infection harbors. It is not amoebic, it is a pyogenic abscess. Multiple liver abscess in the left lobe of liver, it is a pyogenic abscess. So where the source of infection probably lies, which disseminate multiple in the multiple organ.
Tuberculosis, sir.
Sorry? I couldn't get you. Repeat your answer. You should examine the cardiovascular system for infective endocarditis, murmur, because that is the source. There is a multiple abscess can occur in every organ, liver, spleen, everywhere. So if it is a lab, always rule out the cardiogenic infective endocarditis. Okay, go ahead.
Is there any difference between pyogenic abscess and pyemic abscesses? Why these two terms are different? One is pyogenic abscesses and one is a pyemic abscesses.
Pyemia means pus in the blood, intravascular system, sir.
So pyogenic abscesses are localized pus collection caused by bacterial infection, okay, commonly occurring in liver. But pyemic abscesses are type of septicemia where infectious emboli spread through the bloodstream, causing multiple smaller abscesses. Pyemic, multiple. Pyogenic is usually single large abscess. You think of this patient, the CT scan is needed. If ultrasonography is showing me the amoebic liver abscess, then why you did a CT scan on this patient? And which is better, CT or MRI? Why you did a CT scan in this patient? There must be some indication that you did a CT scan and you are not happy with the ultrasonography report. Just I'm asking you whether you will go every time for CT scan abdomen for such patient.
Sir, not every time we go with the CT scan, but if sonography is findings are not corroborating with the clinical picture, then we might want to get an objective view by.
So which is better, CT or MRI? You are thinking about this is just a secondary pus infection, but underlying tumor is there, or some underlying some pathology is there. Hodgkin lymphoma is there, hepatocellular carcinoma is there, and necrotizing abscess is there. Which is better? You want to do CT or MRI?
For a better soft tissue differentiation, MRI would be a better.
MRI will be better, which will show exactly the what type kind of the mass it is. Okay, ठीक है. Okay, then now what? Now what? How will you treat this patient? Now your diagnosis is confirmed as a single amoebic liver abscess. The size is very small, I think. How much it is? See, huh? The CT scan, the size is very small, 5 by 5 centimeter, 7 by 7 centimeter. So what must be the 7 by 7 by 7 centimeter? So what must be the volume of the pus inside? You said you will see whether it's a liquefied or solidified. You will start a treatment, injection metrogel. How much metrogel you give? When you give IV, how much metrogel you give when you give IV?
We give,
you give?
Sorry, sir, we give 500 milligrams 4 times a day.
Yeah. So you give what? 100 ml or 200 ml? I've seen in practice that many people give IV 200 ml 8 early. Is it correct? Or 100 ml 8 early is correct? How much 100 ml of the metrogel contain metronidazole? You must see how much the dose, what's happening, what is the international protocol, what is the ICMR protocol. They're all given. Okay. So usually when you give IV, there's no need of giving 200 ml early. Usually you can give 100 ml early because it almost contains 700 milligram of metrogel per 100 ml. Okay. But when you give orally, then you have to give 800 milligram. That's why you give a double dose. Okay. Anything else? So you start a treatment. Then, if a volume is large, how will you decide when to aspirate and when to not?
If the volume is large, if we can see that there are some
how much volume? How many amoebic liver abscesses you have seen till now, and what is your opinion regarding metronidazole and its action and resolvement of the small liver abscesses? Does it get resolved completely with metrogel, and how many days metrogel to be given? Abhi amoebic liver abscess is there. You are diagnosed with amoebic liver abscess. It's a small, say 5 by 5 centimeter in size. You don't want to aspirate. You are giving a metronidazole. So how many days? 1 week, 2 weeks, 3 weeks, 4 weeks, 6 weeks? And when you should repeat a sonography? You should follow the patient, what is happening, whether he's responding to the treatment or not. Correct?
Yes.
So what your institution gives? This is a amoebic liver abscess in your institution.
So
how you treat?
So we give IV metronidazole.
Okay.
And if the patient is improving clinically, then we wait and we wait for about a week to see.
You give only metrogel or you give any other antibiotic also broad spectrum? And if you give, why?
Sir, sometimes it can get secondarily infected.
Yes.
That's why
Okay.
we
Yeah. Okay. So how many days you give? You give 3-5 days. Then you discharge the patient. What you do? What is your protocol?
so if the patient is improving clinically, there is no fever,
Hmm.
the pain is settled, then we
Hmm.
discharge the patient and ask for a and on a follow-up, we ask for a screening.
So you discharge the patient on 3rd day or 5th day. So how many days you should continue the metrogyl? Total for this 5 by 5 centimeter or any abscess metrogyl. You can give metrogyl for longer period.
No, sir. Usually, after about 7 days, we should stop.
Okay. So at least 2 weeks, 14 days you give metrogyl. Okay.
Yes.
And most of the time, patient don't need other more than 14 days metrogyl. Most of the amoebic liver abscess get resolved. Okay. Now, what size of the abscess you will need aspiration, and why you do aspiration?
To prevent the
See, they give volume. They give it is 50 cc, it is 100 cc, it is 150 cc.
so most likely the amoebic liver abscess, if it is impending to perforate in the peritoneum or in the lung,
Yeah,
then we should aspirate the abscess to
yeah,
become.
yeah. It's if it's liquefied, okay, it's
Yes.
more than 100 ml. You should aspirate. Okay.
Yes.
What about your opinion about pictal? Does pictal is needed in every patient?
If the whole of the abscess is not liquefied, then we can put in a pigtail and let it drain out eventually.
What are the fear complications of pigtail? Though we are using the pigtail, but if it is for amoebic liver abscess, what
How
are the
thick?
fear
How thick?
complications?
How thick is the amoebic liver abscess, and how what is the size of pigtail you put,
Hmm.
and how much that pigtail drains? There are a lot of question, discussion, but you should know whether it's good, bad, what is it? And sir is asking, what is the complication of pigtail?
Hmm.
See, you must have seen a lot of amoebic liver abscess. So the way you treat in your institution, you should able to tell us. Okay,
Yes.
there's a protocol, na? This abscess to be treated like this.
Yes.
There is nothing from the book we are asking. We are just asking how will you proceed with this CT scan and the more clinically and more practical approach of what you'll do. So it's a 200 ml abscess. So you aspirate. Then what is it? What is this the pus called?
Anchovy sauce pus.
Anchovy sauce. Why is the anchovy sauce pus?
It is like a dark brownish chocolate colored sauce, which
Mhm.
which looks similar to anchovy sauce, which is a condiment.
Okay. So usually if you aspirate even 150 to 200 ml pus and keep the patient with the metrogyl, most of the patient get revived and many time a pigtail does not require. But nowadays, I don't know. Everybody start putting a pigtail and pigtail doesn't drain. We keep it for 7-8 days and pigtail it has its own complication like erosion into the liver, erosion of the vessels of the liver, erosion into the biliary tract, and something else can start coming from that pigtail other than the abscess. Because
Another is the amoebic cutis. Amoebic cutis.
yes,
Infection spread
ambiguity.
to the
Sorry.
skin also.
Yeah.
Amoebic cutis.
Very, 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 very true.
Uh,
Okay. Okay. Next. Any other questions from the experts or
yeah.
whatever?
Last questions. If this patient is a suppose a amoebic liver abscess diagnosed on sonography as a first trimester of pregnancy, so which is a safer antibiotic instead of metronidazole in first trimester of pregnancy? It is hardly seen, but sometimes with pregnant women, first trimester liver abscesses, liver amoebic abscess is diagnosed, which is safer antibiotic instead of metronidazole. If you are not knowing, then I just tell you the answer, so we can move to the next. it is tinidazole is safer than metronidazole because it requires a shorter duration of treatment. So tinidazole is a better in a case of pregnancy.
Yeah,
Okay.
tinidazole as such gives a very excellent results. Yeah.
Yeah.
So
Okay.
there's a question in the chat box. What any role of luminal amoebicides is there?
I don't use nowadays luminal amibicide at least whatever, because we get a lot of patient in Rajawadi Hospital only with liver abscess, at least 5 to 6 per month, and everybody is getting nicely treated with only one single metronidazole,
Right.
and we aspirate it and they go home very nicely. So I don't know other people if you are using luminal. This just for the I think just precautionary I think prophylaxis. So there won't be any recurrence. I think luminicidal maybe also should get killed. For that reason, you can use luminal amibicide, but I think metronidazole oral also gives a good results. And according to me, whatever patients I'm seeing on daily basis. Okay.
Yes.
Yeah. Next.
Mathur sir, Supe sir, any questions that you want to add?
No, I think she should have.
सुपेसर यूज करतात का luminal amibicide? आता करता का यूज? आपण तर पूर्वी एमिटिन डिहायड्रोएमिटिन we used to use. What an excellent result history I am.
Nowadays,
it used to have very excellent result. Emetin and dihydroemetin, full resolvement of the amoebic liver abscess within 6 to 7 days. But it is almost a cardiotoxic.
sure.
Okay. Yeah,
So the
next.
metrogyl works for both.
Yeah.
Okay. It is both for luminal as well as through the blood. It goes into through the portal circulation. It goes into the liver. Okay. So
Yeah.
that is the reason why before the metronidazole, yes, we used to use the two drugs, but nowadays it is not necessary.
And Supesh, do you need a CT is always needed for the amoebic liver abscess if the diagnosis is confirmed on ultrasonography?
No. I think what she answered, normally most of the decisions can be taken on sonography. But if you think
Yeah.
a borderline rupture or patient symptoms are not corroborating, then only we will do CT.
Yeah.
I think that's very right. And only
Yeah.
thing is, today most of the people give IV because it acts very fast and patient
Yeah. True.
control. Because
Yeah.
oral, if you have to give 800 milligram, which most of the time causes nausea. Not that it
Yeah. Double dose. Yeah.
better tolerated. That's the only thing I think so.
Yeah. Yeah. Next one. Next candidate.
So the third candidate has not joined today.
Acha.
So either we can finish or we can show the third and ask both the candidates to answer questions.
Yeah,
However,
that will be nice. What is the next third
That's
slide?
Yeah,
Whatever.
that's good.
Dr. Shubham was supposed to join. He has not joined. I've called him. He's not picking up. So this is the final this thing. But then
Yeah,
both
this
the
is
both the students can answer any
yeah,
questions.
ये तो most interesting है.
Yeah.
Yes.
इसमें तो पूरा रात जा सकता है, लेकिन ठीक है, whatever.
Yes.
Shravani, what is the differential diagnosis of this X-ray?
Sir, since this X-ray is showing air under the right hemidiaphragm, it must be a hollow viscous perforation, sir.
Free air under the diaphragm. There is a lot of air under the diaphragm. Use the word free air.
Shravani, how will you differentiate free gas from the confined gas on X-ray?
Sir,
Your undergraduate students or intern is asking, okay, yes, doctor, how to differentiate free gas under diaphragm from the confined gas under diaphragm on X-ray? What will be your answer?
Last stomach bubble with a fluid level. You will
yes,
say
sir.
gas under diaphragm?
No, sir. Since it
No,
has
it is
a
under the
fluid-
diaphragm. It is not free gas.
Yes, sir. It is a loculated or
No, but
collection
how
of
to
that.
explain to the undergraduate or the UG or the intern on X-ray? So in one word, I take the gas which conform, CONFORM. Conform means to take the shape of diaphragm is a free gas, which does not take the shape of the diaphragm is a confined gas. In this is the confined gas here. So you can see the both free gas as well as confined gas in the left side.
Yes, sir.
Pandas.
Yes.
The next question is you are telling it is hollow viscous perforations.
Yes,
What
sir.
are the other causes?
Sir, it can be post-operative, sir.
Post-operative,
after
very
an
good. Third
operation.
thing, post-operative. Third,
Sir,
any obstetric procedures in the past time, not done nowadays. Obstetric
sir,
investigations.
hysteroscopy, sir.
It is not. It is a Rubin's test. What is Rubin's test? It is
They put
injecting the
Sorry,
air
sir.
through the cervix, and to take the X-ray, if free gas is visible, it means minimum one fallopian tube is pattern. Nobody can tell it is a right or left. Minimum one tube is pattern. It may be the both. A minimum one tube fallopian tube is pattern. Okay.
Okay.
So how will patient present to you?
Sir, patient will present, sir, he might be presenting with tachycardia, features of shock, sir, hypotension, breathlessness, and
if this
sir,
patient
acute.
is a duodenal ulcer perforation,
Yes, sir.
are there any stages of presentation of the duodenal ulcer perforation? Do they present different in first 6 hours, in next 8 hours, then afterwards? What is, you know?
So Ajay sir is indirectly asking the pathogenesis of peritonitis. Different phases, if you have
Uh,
read very well, pathogenesis of perforation, perforative peritonitis.
Because most of the residents
yes,
nowadays
sir.
I'm asking, they don't know about this. What is the importance of the duodenal perforation patient coming within 6 hours to us, or within 18 hours to us, or after 24 hours? What big difference
Yes,
it
sir.
does make?
So initially, there would be just inflammatory signs like
Inflammatory sign.
fever or vomiting, and later, sir, the patient will become more toxic as the peritonitis will, sir, aggravate. The patient will come with generalized tenderness and rigidity of the abdomen, and
So first stage, first
would
6 hours,
be
patient
yes,
come with due perf, and after 24 hours it comes. Does it make any difference? How the presentation will differ? Clinically, clinically, patient come to your casualty in first six
yes, sir.
hours, young patient, say 26-year-old patient,
Yes,
come
sir.
with a due perf, immediately he come within 2 hours because of severe pain. And
Yes,
he
sir.
comes after 24 hours, he's taken some analgesic, he says, okay, I was feeling better, but again he deteriorated. See, the first 6 hours, whenever there is a perforation, it's basically a chemical peritonitis.
Chemical
Okay.
peritonitis.
Then it goes into the stage of delusion or hallucination where the peritoneal fluid get dilute the chemical. Okay. And that's why the patient's
Okay, sir.
symptoms can go down. And then after 18 hours to 20 hours, patient go into the frank peritonitis because of the secondary infections and bacteria grows very fast. So the presentation are first few hours, especially in duodenal ulcer perforation and gastric perforation, there will be a tachycardia because of the pain. You will get a
Yes, sir.
signs of tenderness, guarding. You will get, but
Yes, sir.
patient won't be in a shock, hypovolemic shock many times. But as the
Okay.
hours increases, chances of the patient going into the hypovolemic shock and septicemic shock,
Septic.
whatever you say, are higher. Correct.
Okay,
So
sir.
according to that, you have to start a treatment to the patient.
Yes, sir.
Yeah.
If you have read the Love Bailey, there is a sketch work. Hamilton Bailey is looking up the patient's abdomens, how the abdomen moves. That is the stage
Yes,
of the
sir.
different peritonitis. First 4 hours, then 4 to 6 stage of delusion, and then the bacterial peritonitis. Okay, I just tell you this patient presentation. Patient is a 94 years old female with mild abdominal pain. X-ray
Okay.
shows free gas under diaphragm. There is a no tachycardia, no pain. On per abdomen examination, it is a soft, non-tender, guarding rigidity is also absent. What will you do?
These
If
questions are
you
both for Dr.
so if
Shravani as
if
well as for Dr. Kshitija.
yeah, no, it
Kshitija,
is
if you
open for
know,
both.
you can also answer.
Should I repeat the history and examination part
Just
once
listen
again?
it
No, sir.
carefully. It's very nice question. So
Yeah,
just listen it
94-year
carefully.
old lady with a mild abdominal pain. She is a very comfortable.
Yes, sir.
She had a no vomiting, no fever. Vitals are normal. It is pulse is no tachycardia. On per abdomen exam, it is soft, no tenderness, rigidity guarding. X-ray shows the free gas under diaphragm. What will you think of and what will you do?
Many time it happens with younger patient also, not necessarily
Yeah,
94-year
sometimes in
old.
younger patient.
They come, we get a gas in their diaphragm, but they are so much stable and settled.
Sir, it
Why?
can be a sealed off perforation.
Yes. Okay.
Yes, very good answer. Where it is cells of perforation. So
Yes, sir.
you have to observe the patients, keep the patients nil by mouth, and
Yes, sir.
keep it hydrated. Observe whether the signs of peritonitis is increased, means tachycardia, increased tenderness or rigidity guardings. And
Yes,
after
sir.
how many hours or days will you start oral, and what will you look after starting oral?
Sir, after about 3 days, sir.
Yeah, it is usually 4 to 5 days, because it is a time it gets very much heals ulcer perform side, very seals up very nicely. So after 4 or 5 days, you can start orally. And what will you look for after starting orally?
Uh,
Of course, first
Sir,
liquid
any
diet and then
signs
the
of
all
peritonitis,
these
sir?
signs which are absent that I spoken, you have to look for that.
Yes, sir.
And when will you discharge the patients?
Sir, after the patient is tolerating soft diet, sir.
Oral food, and he has passed the stool defecate,
Fast
means
foods.
his system is working well from
Yes, sir.
eating to the passing stool. Ajay
Yes.
sir, I had 94 years patient, that's why I give the similar example. I keep it
Okay,
conservatively.
okay. Yeah,
She
yeah,
had a seals of perforation.
yeah. So you
Okay.
explore, if you
Uh,
explore this patient,
yeah.
can you
Yes, sir.
find out on exploration and looking at the perforation, whether it's an acute perforation or whether it's a chronic perforation?
Yeah, that is a good question. How will you decide?
Sir, looking at the margins of the perforation, sir.
Hmm?
Hmm?
Uh, Sir,
What
if
happens
there
in
is a
chronic peptic ulcer disease to the duodenum?
sir, in acute, there will be hyperemia of the edges, sir, and they would be friable and more inflamed. And
Hmm?
in chronic
There
ulcer
won't be any
perforation, sir,
changes
the
of chronicity in the duodenum, no? There is any. So what is chronic? Chronic duodenal ulcer changes? Is it? You see, we must have seen a lot of perforation, no? Duodenal ulcer
yes, sir.
perforations. Still, they come in municipal corporation. They do keep coming, but usually nowadays we get a lot of acute perforations because of the bad drug habits or whatever analgesic they take from the shopkeepers. Okay. So that's for that you have to read a belly love properly of peptic ulcer disease. And you should know what is acute ulcer, what is a chronic ulcer. Okay. You have to read a lot.
Yes.
Basic belly love also gives a lot of things. After exploration, what are the findings? Chronicity you see. There is a lot of thickening, induration, cicatrization of the duodenum.
Cicatrization.
Okay. These findings are seen. Okay. Which ulcer perforate and which ulcer bleed and why? Where the ulcer is situated, which perforate, and which ulcer is usually bleed at which site of the duodenum? First, second, third, stomach
Mostly
perforation.
D1 ulcer perforates more, sir, and anterior ulcers perforate and
Yeah,
posterior ones bleed, sir.
yeah. So if there's a lot of bleeding, patient is massively bleeding posterior duodenal ulcer perforate. How will you
Yes, sir.
diagnose and what will do?
Sir, a patient might present with sir, hematemesis and
Yes,
melena.
yes. Hematemesis,
And
yeah, a lot of hematemesis.
yes, sir.
Then,
Uh, and hypovolemic shock, sir.
yes, hypovolemic shock with a lot of pallor. So what usually they do? How they diagnose?
Sir, we diagnose it endoscopically, sir.
Many times there is a lot of clots, very difficult to diagnose. But yes, you can go up to D1. Sometimes we are seen as spurting, spurters
Yes, sir.
on the posterior aspect of the duodenal
Yes,
ulcers.
sir. We can do endoscopic ligation of the spurters, sir.
Yeah, and if endoscopic is not possible, then neurites, it's bleeding continuously. Endoscopy fail. They are not endoscopist. So what you'll do?
You have to explore the patient
Explore the patient and
and take a figure of 8 stitch at
yeah,
the
you can really directly open it and directly take a stitch over the bleeding duodenal ulcer.
if
अभी नया टेक्निक से क्या नया 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 कुछ होगा?
Interventional radiology can
Yeah, intervention radiology. But if the patient is unstable, it's better to go for surgery because angioembolization, celiac vessel embolization, gastroduodenal vessel embolization may take time.
yes.
And the patient is losing a lot of blood. It's very easy to open up the patient and do the surgical procedure. Okay. What else? What else? Gas under diaphragm. Which other bowels you have seen with gas
Stomach.
under diaphragm? Stomach. If the stomach
Sir,
perforation is there, what you must do while before suturing the stomach? Patient
we
is
should take
60-year-old.
edge biopsy, sir.
Yeah, you should clear the edges and you should take a good biopsy of the
Ulcer, sir.
what else perforation you have seen?
Sir, I have seen a younger age group also and elderly also, sir.
Huh? No. What bowel perforation you've seen?
Sir, I
Diverticular.
have seen an eye.
You have seen a duodenal, you have seen a stomach, you have seen a jejunal, ileal. Which one you have seen?
Yes, sir.
What are
Ileal
the
perforation.
what are the causes of ileal perforations?
Sir, it can be a typhoid ulcer or a tubercular ulcer, sir.
Yeah. So if the patient come with a ileal perforation and lot of contamination, patient is 65-year-old, lot of contamination and there is a large perforation in the ileum 2 feet away from the IC junction.
Yes, sir.
And but contamination is there, patient is in septicemic shock. What you'll do?
Sir, we will do an
Hypovolemic. You
We'll
are given a lot of
resuscitate the
fluid.
patient first.
Yeah, that you did. And you have taken the patient, but there's a lot of contamination. 2 liters of fecal contamination, biliary contamination, fecal contamination.
We will do a ileostomy, sir.
Yeah, it's better to do the ileostomy for such patient because many a time this patient may come very late to the casualty, and we operate them late, and many a time leakage chances are very high. So you can come with the ileostomy, and later on, when the patient settle after 2 or 3 months, you can do the ileostomy closures.
Reversal.
Okay. Any other questions? I asked a lot of questions.
Sir, I have one question for both the students.
Yeah.
Is there any non-operative management for duodenal perforation? Yes or no? Non-operative management of duodenal perforation.
Non-operative
एंडोस्कोपिकली कुछ
maybe
करते हो क्या आप लोग अभी? कुछ सील करते हो क्या अंदर से?
Yes, sir.
Okay, क्या clips?
Endoscopically, we can
Endoscopically
do
clips.
clipping. Yes,
Okay.
clipping.
Okay. How are the results? Good? How are the
Not
results
so,
of the
sir.
endoscopic clipping? Are they good?
Sir, there is a risk of slippage.
No, I'm not asking you.
Slipping.
No, I'm asking to the person who is giving the answer.
No, sir. Actually, I was going to the part that if it is a posterior perforation and if it's a very small contained leak, we can keep the patient conservative
Okay.
and just observe.
Actually, we talk about the seal perforation in the beginning, sir. I asked the question about the seal perforation.
Yes. So that's
I
called the
think it's a
Taylor
10
regimen.
p.m. and we actually did a lot of things in 1 hour. Any other questions from the experts or whatever? Because this question.
Supe sir, Mathu sir, any questions or should we end for today?
Okay.
No,
What is the
I had
differential
one
diagnosis
question.
of this gas under diaphragm,
Mhm.
particularly on the right side? If it is not seen on the left,
Yeah, it is
only
on the left
right
side also,
side.
I think, sir. I think, sir,
No,
it's on the
here
left
it is.
side.
Here it is seen on both sides.
Ah.
But if it is only seen on the under the right dome of the diaphragm,
Yeah.
what is the differential diagnosis to both the students?
TLDT sign.
Due to?
Sometimes the colon can get interposed between the liver and the diaphragm.
So what is that known as?
Chiardity sign.
Chilaiditi syndrome. Very good. Chilaiditi.
Chilaiditi syndrome.
Okay. Or
how the subdiaphragmatic abscess on right side look like on X-ray? subdiaphragmatic abscess on right side. How does it look like on X-ray?
So it can look similar to the air under diaphragm and can sometimes show air fluid levels. Like
Only single airflow, below is the pus and above is the air. It may be seen, but that is a distinct level of fluid you can differentiate. And what is meniscus signs? Anyone?
That is seen
Shravani?
usually in a pleural effusion, sir. If it is extending into the pleura, we can see a meniscus sign.
So it is a concavity of the fluid. It is a that is what it is a, whether it is pleural fluid or abscess cavity. That is meniscus. It takes a concavity, so you can differentiate that there is a below is the fluid and above is the air. So that is a meniscus signs, just like meniscus. Okay.
Okay. What are the
Ajay
causes
sir.
of large amount of gas under diaphragm?
Yeah.
Where will you suspect what site of perforation is? If there is large amount of gas
A
under
large
diaphragm.
bowel perforation, sir.
And
post-operative.
okay, we are talking about the
How long
perforation.
post-operative states gas?
Yeah, yeah.
How long?
Normally, post laparoscopy, the gas can stay for up to 2 to 3 days. And the laparotomy, it can stay for up to about 3 weeks.
Okay.
We are talking about the perforations only. Which
Large-
other hollow viscous will give rise to large amount of gas under diaphragm?
Gastric perforation, cecal perforation.
Yes. So large bowel and the
Large
gastric.
bowel and gastric.
Gastric.
Yeah, good presentation, good answering.
Good.
Not very bad. I feel it was good. Okay. Yeah.
Thank you.
Shall we end this session because I'm hungry now?
Yeah. Thank you, Dr. Bhujan.
Yes.
Okay. Yeah.
Thank you, Ajay sir. Thank you, Jayesh sir, for
Thank you
joining
so
today.
much. Yeah.
Thank you so much,
Yeah.
sir.
Nice
Good night, everyone.
discussion. Thank you.